Good morning and welcome, or good evening, depending on where you're calling in from. Welcome to this webinar on the global church and family planning. We're glad you've joined us for what we hope will be an informative discussion. I'm Daniel O'Neill, the founder and managing editor of the Christian Journal for Global Health, and I will be moderating this meeting. It's well established that healthy timing and spacing of pregnancy leads to significant reductions in antenatal, neonatal, maternal morbidity and mortality, and to reductions in poverty cycles. Christian faith-based organizations and churches are in an important global position to utilize faith-based frameworks to affect change in behavior, access to services, and education for promotion of human flourishing to meet or exceed the Sustainable Development Goals. This webinar will highlight innovative approaches from 3 faith-based organizations. This webinar is sponsored and organized by Christian Connections for International Health, a network of organizations and individuals promoting global health from a Christian perspective. And we'd like to give special recognition to Mona Bormed and Kathy Erb, who are working behind the scenes, pulling the strings from backstage. And we'd also like to highlight the sponsorship of Christian Journal for Global Health, a peer-reviewed scholarly multidisciplinary journal on global health policy and practice, promoting evidence-based and thoughtful discussions on effective and innovative approaches to global health from an integrated Christian perspective. The programs presented are detailed in a special issue published in July 2017, along with many other articles on family planning. This issue was sponsored by an APC grant from USAID. The table of contents and open access to full-text articles can be found at journal.cjgh.org. Our 3 speakers today are Marg from Wise Choices for Life, presenting a program from Uganda, Susan Otchere from World Vision and a program in India, and Sharon Tobing from Adra from a program in Nepal. During this webinar, please enter questions in the comments section and we will endeavor to address those after the 3 speakers have presented their respective material. Our first speaker is Marg. She is a midwife and director of Wise Choices for Life. A fascinating program on educating men in sexual and reproductive health with a pilot program in Uganda. She published her article entitled Increasing the Church's Relevance and Impact in Poor Resource Areas by Adding Sexual Reproductive Health to Missional Activities. She joins us from Australia. Welcome, Marg.
Thank you very much, Dan. I'd just like to say that I'm speaking from Australia, but I'm speaking on behalf of my wonderful friends and workers in Uganda who do all the training, and it was impossible for them to be involved, so I'm representing them. Thank you. So this is our theory of change, and we realise that reducing maternal mortality in Uganda is going to really need a holistic approach to the subject of sexual reproductive health education, and it really needs to be led by the men. The vision of Wise Choices for Life is to transform lives and reduce maternal deaths, orphan numbers, and poverty in Africa. Knowing we are all made in the image of God, the mission of Wise Choices for Life is to empower vulnerable youth with knowledge and life skills in reproductive health and parenting to achieve poverty reduction. So we encourage, we equip, and we empower men and women, but our focus is men, to take reproductive health education into a variety of settings where the youth are. It's in schools, in prisons, churches, youth groups, sporting facilities, parenting groups, and this is to reach the boys and the girls, but we do believe that if the boys are reached, then the girls will be cared for. Ignorance, cultural traditions, myths, and silence on sexual reproductive health drive the behaviour, and we believe this can change. So phase 1 is the Wise Choices for Life 1-week training, which includes both written and practical assessments. It's a very practical course. Phase 2, the clients return home and they begin to share their learning with friends and family. And we like them to do it in 2 ways. There's often scatter, which is learning through very large groups across communities, often through church or sermons or very, very large youth gatherings. It's very hard to monitor that. The second way is focused intentional groups. We've called these FIG. These are regular, smaller groups that go through each lesson over a series of months. Youth groups, smaller classes at village level, schools or prison. And this is a really effective way because the trainer then becomes a mentor, and that works well. Phase 3, after the clients have been implementing their new skills through Scatter and FIG, they may choose to host a one-week workshop in their area. So these photos show a couple of men learning all about pregnancy and birth. It's very different for them, but all the lessons have got a practical component. And the second photo shows a young boy in a classroom who's talking to his peers about menstruation. Thank you. Phase 4. Once a program is established in a particular area or country, Wise Choices for Life provides follow-up. This includes mentoring and coaching the leaders from Australia. And we guide the emerging leaders through sharing knowledge and learning. So this photo is taken in the Ugandan boardroom of the Church of Uganda, and we've got pastors learning all about conception and pregnancy. So what's taken us by surprise is the work in the prisons. We're now working in schools, which is, I think, where we thought we would spend most of our time, but we're going into youth centres, men's and women's prison, and it's really taking off quite strongly in these areas. So coming up in November, we have our annual Kampala conference. It's actually situated in Mukono. And we have Train the Trainer workshop in sexual reproductive health family planning. Registrations are about to close for that, but there's a few places left. So using male and female leaders from faith groups, we train on how to control fertility, starting with puberty and ending with family planning and environmental issues. The curriculum is a very critical mix of both faith, science and culture. It's an open forum for people to discuss all of these things in a very safe environment. We use drama, dance, song, discussion and debate. And these communication skills are really developed very strongly. So here we have a reverend and a fellow worker learning all about the woman's cycle and conception. So we have what I call partners. They may not be financial partners, but we have endorsements from the Uganda Ministry of Health, the District Department of Education, local compassion workers, the Church of Uganda, and the Ugandan Christian University. And there are multiple smaller organisations and churches that join us. We haven't been financed by them, but we are moving along strongly and a real respect for each other. Along the way with all of training, we actually have communication skills, decision-making skills, critical thinking skills, and these are the things that make a big difference in helping to shift behaviour. Thank you for listening. Once again, I'm speaking on behalf of my Ugandan trainers, and that's Joyce there in front of a whole group of young people talking about pregnancy. Thank you.
Thank you very much, Marg. We appreciate that informative presentation. For those who joined a little later, we would ask you to enter any questions, but we will answer those questions toward the end of the 3 presentations. Our next presenter, we're pleased to have Susan Otchere. She is a project director of Mobilizing for Maternal and Neonatal Health through Birth Spacing and Advocacy, or MOMENT project of World Vision. She and her colleagues published the paper entitled Social Accountability in Education Revives Auxiliary Nurse Midwife Centers in India, Reduces Travel Time, and Increases Access to Family Planning Services. So welcome, Susan.
Thank you, Dan. And thank you everyone for joining us. Yes, and so my presentation outline is going to be giving you an overview of the objective, the background in India, real-time issues that we identified during the baseline, our project interventions, results, and challenges and lessons learned. So the Moment project was implemented in 4 countries, the US, Canada, Kenya, and India. The Kenya and India were field-based programs. And the overall goal was to improve maternal and neonatal and child health by creating global and local enabling environments for maternal, newborn, child health services provision and use. The key objective in the India setting was to strengthen community knowledge and civic action for improved service delivery and use of healthy timing and spacing of pregnancies and family planning services in 2 districts, that is Hardoi, which is a rural district, and Lucknow districts in the state of Uttar Pradesh in India. So just to give you a sense of where Uttar Pradesh is in India, you see on your screen, and where our implementation sites were. In rural Hardoi, we served a population of about 300,000, and in Lucknow, we worked in 60 slums. Also, here are some population numbers to give you a sense of what Uttar Pradesh statistics look like. You can see that the fertility rate is higher than the national average, and unmet need is also high. Key issues that we identified during the baseline are listed, and I'd like just to mention that there was inadequate knowledge on the importance of timing and spacing of pregnancies and how to achieve that through the use of modern methods of family planning. Geographic access to maternal and child health and family planning services was an issue, and India has a program where communities can access government funds for social and health services, but communities did not know about this. So we developed targeted interventions, and one of the first was social and behavior change communication to educate the community, to educate local elected leaders, to educate the local village heads, the grand panchayats, so that we garner their support. So some of the behavior change activities that we developed are on your screen. I'd like to point out the one that has the modern methods of family planning offered by the Ministry of Health. And you can see to the left of that, we have our 4 key messages on healthy timing and spacing of pregnancy. To your far right on your screen, you'll see another picture with electrodes. This we call the electro game, and it's a continuum of care. It spans a continuum of care from reproductive health, breastfeeding, nutrition, methods of family planning. And so it's a Q&A. So once we point to a box and you get it right, the light comes on, and it really took to the hearts of the men. So we got men engaged at that point. And you can see that there are at the bottom of your screen, we developed snakes and ladders around the issues and painted messages on the walls in the communities. Our second key approach was social accountability, and in World Vision, our social accountability approach is the citizens' voice and action, where we used to bring communities and local leaders and health care workers together. However, we found that in India, the word citizens' voice and action or social accountability was a bit off. So we used the term interfaith meetings, where we use as a venue to educate defunct village committees. We used it to educate the community on their government entitlements, and actually to point them to the fact that they could access certain funds from the government to improve social and health services. And open also run down or closed auxiliary nurse midwife sub-centers, which is the first level of care for villages and communities in India. So then what were our results? Using our social accountability and education approach, you can see on your screen where we bring men and women together to talk about the issues And also to the right of your screen, the top right, you see the community scorecards that we use to determine whether a service was good, bad, or okay. And on the bottom of your screen, you see the members of the community in action. So based on the social accountability interface meetings and Otchere, the village leaders and community development officers work together to access what is called untied funds from the government and use it to refurbish these auxiliary nurse midwife sub-centers. So you see the before and after on your screen. So after we had opened the sub-centers, we actually opened 17 of the auxiliary nurse midwife centers during the 3-year period of the project implementation. We also were able to revitalize 40 village health committees. And so with the reopening of the sub-centers, we improved access, we created access to modern methods of family planning, and the numbers are on your screen. And also, in addition, we open access to antenatal care, nutrition for young infants, and other needed services. I'd just like to give you an overall project data for the Moment project in India. So we have the contraceptive prevalence rates at 39% during our baseline, and when we did our endline survey, we reached 47%. So achieving a 8 percentage point increase. And if we wanted to calculate it in a different way, we actually achieved a 40% increase. That is in the Hardoi district. We had many challenges, and I just like to share one of the key challenges is that the community did not know about the government entitlements, and so it kind of snowballed them not knowing that they could maternal and child health services and family plan services could actually come closer to them, and that they need not travel to the primary health center or the community health center. Our lessons learned is that social accountability using community scorecards can help mobilize communities to access, the government funds that were available to discuss and to contribute to improving services that affect them. And also the knowledge that we imparted to the communities helped them connect the dots between timing and spacing of pregnancy, the health of mothers, and the health of children, and how to achieve timing and space of pregnancy by using family planning methods. So as a faith-based organization, a lot of us think of that we don't support family planning. We do support family planning, but it's in this, the basis is to help women in their fertility. And to choose healthy timing and spacing of pregnancy. So I want to leave you with why World Vision is well positioned to scale up the use of family planning through HTSP and social accountability and other strategies. And with that, we are building a body of knowledge. And as you see on the screen, we have a number of projects surrounding HTSP. One of them is this current project Moment that we implemented. We also, and interestingly, and we're excited to say that in Kenya, the Moment Kenya project, we used the results to submit a proposal to the Templeton Foundation, and now we're scaling up from one sub-county to the whole of the sub-county, which has 6 sub-counties. So we're really excited, and we're going to start just this September or October, since September is over. We're also part of the Advancing Partners Communities USA project with JSI, and we're also integrating HTSP into existing maternal and child health programs run by the Ministry of Health. We also have another HTSP project which we are integrating into child welfare clinics where immunization takes place, and this is funded by the Pfizer Foundation. Another exciting thing that World Vision is doing is to test, we're undertaking an operations research to test our channels of hope methodology, which is a methodology that works with faith leaders and conservative groups on the issues of HIV/AIDS, family planning, gender, and why they should support it. As Marg presented, many of us or many faith leaders don't even know how conception takes place. So, and helping them, Channels of Hope also helps them to understand the big picture surrounding pregnancy, the health of mothers, and the health of newborns and children. And also, we do also work with Channels of Hope in HIV/AIDS programs supported or funded by USAID. So I just wanted to leave you with that. As an FBO, we do support family planning to help women have safe deliveries, healthy children, and healthy communities. Thank you. And I do want to acknowledge the Uttar Pradesh state government, donor support from the Bill and Melinda Gates Foundation, and our project team in India.
Thank you very much, Susan. Thank you very much. Very informative presentation. The interfaith approaches, the sub-centers, the partnerships that have developed capacity to change behaviors, and the importance of measuring and evaluating the results. We'll have a few more questions for her toward the end, so we'll get to our next speaker, but prior to the question and answer session. The next speaker is Sharon Tobing. She is Program Director at Adventist Development and Relief Agency, or Adra. She will be discussing the results of the study published by her colleague, Ghanshyam Bhatta and colleagues, entitled The Increasing Access to Family Planning Services Through a Non-Health Sector, Technical Integration Coverage and Access, or TICA, in Nepal. So welcome, Sharon.
Thank you so much. And hello, everyone. I'm very excited to share with you some of the family planning learning which took place in Adra, Nepal. And I'm stepping in for my colleagues in Adra, Nepal, who've been incredibly overstretched with flood response. Adra, Nepal is one of a network of 131 country offices that comprise Adra International. We work primarily in health, education, and livelihoods, and strive for integration of those sectors. In 2016, the latest year for which we have data, we reached over 4 million people with health activities. The Technical Integration Coverage and Access, or TICA project, is an example of the rigorous health activities which Adra promotes. We expect effective programming to bring quality results and well-being to participants. TICA included a descriptive cross-sectional study that I'll share with you in this presentation. Today's talk will progress through a brief overview of TICA and description of the study, and focus primarily on results, conclusions, and recommendations. As background, contraceptive use has largely plateaued in Nepal despite significant unmet need. There are many reasons for the unmet need, some of which include disparity in contraceptive use by age, disparity by religion, disparity by social groups. There's a limited range of methods, and there's limited contact with family planning providers and outreach workers. So mitigating these challenges requires approaches from many angles. One option to meet the gap of unmet needs is finding new opportunities to meet with and engage with potential family planning clients. So Adra Nepal took this idea of increasing options for women to engage with family planning providers by testing integration of family planning into a non-health program. In 2014, Adra received funding for the TICA project from USAID's Office of Population and Reproductive Health to test out this idea. TICA was part of the larger Advancing Partners and Communities program. It was integrated into an Adra Nepal Women's Economic Growth Project, the Develop Local Economy to Eradicate Poverty, or DEEP project, funded by AusAid. DEEP formed and trained women's groups and their leaders while strengthening local markets and cooperatives. TICA layered and integrated family planning and reproductive health knowledge and services into the women's groups, the agricultural cooperatives, and the market centers that were created or targeted by DEEP, and included a focus on adolescents and youth as well as male involvement. Adra was interested to explore the effectiveness of a family planning project integrated into a non-health sector, in this case agriculture, and developed a study on this topic. The study design was a descriptive cross-sectional post-interventional study conducted over a 4-month period among 525 women of reproductive age who were participating in the DEEP agriculture program. The study was carried out from November 2015 to February 2016 in 5 village development committees in each of 3 districts where DEEP agricultural activities were being implemented. The size of the sample was calculated at 25% of the 1,800 total agriculture participants, or 450 women, and 25% of the existing women's groups from 21 women's groups. The sample was increased and actually ended up being 525 women from 21 women's groups to account for an anticipated 17% non-response rate. A 2-stage sampling technique was used to select respondents for participation in the study. In the first stage, of the 60 women's groups in total, 21 groups were selected randomly from 3 agriculture program interventions districts. And in the second stage, women were selected who met study criteria. For example, only women who were not previously sterilized. The study ultimately included 179 women from 7 women's groups in Kapilvastu, 228 women from 9 women's groups in Palpa, and 118 women from 4 women's groups in Rupande. Data was collected through face-to-face interviews of the women using semi-structured questionnaires. Data processing included data entry, program development, data entry, and data cleaning. EpiData software was used for data entry. Data was validated before undertaking analysis. The data was then exported to SPSS and checked for inconsistencies. SPSS descriptive was used for data analysis. Multiple responses were organized using multiple dichotomy. The crosstab option was used to obtain frequencies or percentages according to the number of respondents or responses. For all continuous variables, the Shapiro-Wilk test for normality was used to check the distribution of data. When the test was significant and suggested non-normal distribution of variables, a non-parametric test was used. The analyzed data was presented in tabular and graphical forms, and we'll look at some of it in upcoming slides. The findings and conclusions are limited to the intervention group only and may not reflect the family planning behaviors of the entire district population. According to TICA reports, nearly 25% of the sampled women's husbands were working outside of Nepal, so this would have impacted and most likely reduced the proportion of women currently using family planning, and it may also have limited the potential for women to discuss family planning with their husbands. The next 3 slides share some of the TICA study results. In this first slide, a summary of findings comparing end-line and baseline is shown in the table. While almost all of the participants had heard about family planning at both baseline and end-line, a statistically significant proportion of end-line participants had a correct understanding about family planning. And the willingness among husbands to use family planning methods increased substantially from 5.2% to 15.6% compared to the baseline. This difference was statistically significant. Continuing on with further results, the percentage of respondents aware of short-acting family planning methods increased from 86% to 92.3% post-intervention. However, the percentage of respondents aware of long-acting family planning methods increased from 48.7% to 61.5%, and those aware of permanent family planning methods increased from 39% to 52.2%. The trend toward increased awareness of all three types of methods was significant. Of high importance, the proportion of women or associated men using permanent methods increased from 31.1% before the intervention to 44.4% after the intervention. More specific evidence that improved knowledge translated into behavior is seen in this table. If the methods of contraception are grouped into three categories, and temporary would be condom and pills, long-term but reversible would be depot, IUD, and implants, and permanent methods would be vasectomy or mini-lap, then there is a significant trend towards employment of permanent methods. And you can see that vasectomy in particular more than doubled. The study demonstrates the feasibility of integrating family planning into agriculture and potentially other non-health sector programs that may not at first glance seem like an obvious pairing. The research showed that utilization of family planning services could be increased through increased family planning knowledge diffusion and awareness creation, with a high probability of encouraging husbands to use family planning and to be actively involved in family planning decisions. Evidence from the study suggests that TICA activities helped augment the knowledge of family planning among deep agriculture project population. The use of family planning increased among the agricultural program participants with a gradual shift from short-acting family planning methods to long-acting and permanent family planning methods. This was particularly true for the number of couples that used vasectomy as a family planning method, which more than doubled at the end of the study period. Overall, the TICA activities were very successful in increasing family planning knowledge as well as promoting the use of family planning among the targeted women. The study triggers some thinking about potential follow-up work. The willingness among husbands to use any family method remains low, and male involvement in family planning should be a key area for further research and action. Integrating family planning activities with non-health sector interventions is acceptable to communities, and it engages males and youth. It is recommended that similarly integrated family planning program be replicated in the study districts as well as other districts in Nepal. Including family planning activities in livelihoods interventions can increase community support. Since this community approach worked, it could be tested for implementation through other community structures in addition to the cooperatives, women groups, men's groups, and youth clubs, which were involved with DEEP. On behalf of Adra International and Adra Nepal, I would like to thank you for participating in the presentation. And we'll have a question and answer period later, but if you have a desire for further details or any questions beyond what's shared in the presentation and in the published article, please feel free to contact any of us from Adra that are on your screen. Again, thank you.
Great, thank you. Thank you so much, Sharon. Very appreciative of that presentation. We're going to go now to a question and answer session, and we'd love to hear from you. If you have any questions that you'd like to enter into the dialog box on your screen, we'd appreciate that. First question is for Marg. When you say the curriculum involves or includes everything from puberty to family planning, including environmental issues, what exactly does environmental issues mean? If you could explain that, please.
Sure. When we do our training, we ask people questions. So the whole training is not prescriptive. So we ask people what's going on in your area, what environmental issues. And every training session comes up with much of the same list: water sustainability, food issues, deforestation, animals not having the same space, like elephants coming out of forests and trampling villages, cutting forests for wood, burning charcoal, just general pollution of rivers, etc. Plastic bags always comes up, mudslides, and then of temperatures, etc. So then that leads into population control and the impact on the environment. So it's an easy step. So all of our training is through asking questions.
Good, thank you. One other follow-up question. What challenges did you face, Marg, in terms of the innovation that you were presenting?
I think one of the big challenges is helping people to see that male religious leaders are the key to change, and they can help shift non-medical other males, because males are the major decision makers in most relationships. So helping even medical people to see that, hey, we've got all our knowledge in a textbook, and we spend most of our time reaching women in a clinic or a hospital, particularly as a midwife, but really our knowledge is so much, can be magnified if we go to the men. So helping people to understand that shift, and that is better illustrated on the little videos on our homepage of our website. Funding is always a big thing. This was started with my husband and myself, so funding was just through, you know, my family and friends to start with, and it's gradually picked up. So we don't have any major sponsors, so always finding funding. Monitoring and evaluating is massive, and we just don't have the funds and the support people for that. Making the curriculum simple enough. When you're talking about menstruation and family planning, it's quite a complex area of science, and trying to simplify that and still not lose the truth and the essential components, but just making it very simple. I think they're the biggest things.
Thank you. Just one follow-up question then, Marg. Did you see the HIV/AIDS epidemic in Uganda providing a readiness or openness for this project?
Because I've never been in Uganda prior to HIV, so I have to say how I found it, that everybody has been impacted by HIV. So therefore, people are now a long way down the track because they're used to having antiretrovirals. I think people are now saying it's not the complete answer, it's about human behavior changing as well. And so it's very easy to bring in subjects like faithfulness, teenage pregnancy, a huge range of things. So I think HIV actually is right. It gives us a bigger platform, but people are looking for long-term sustainable solutions, and they're finding that themselves.
Good. Well, thank you very much, Marg. It's an interesting theory of change also that structured your program about the capacity of men to influence decisions in terms of family planning. I'm going to turn a question now to Susan. This person said it's wonderful to revitalize communities' commitment. Committees could request funds to open up 17 defunct sub-centers. Is quite amazing. But the question is, who staffed them after they were revitalized?
Thank you, Dan. Yes, we work closely with the Ministry of Health and Family Welfare in Uttar Pradesh, and so with the local district officials also. So really the Ministry of Health and Family Welfare staffed these auxiliary nurse midwife centers. And in actual fact, there were staff posted to these centers, but because they were closed, you know, they were not coming to work, and so it actually caused friction in the community. So once we used the process to bring them together, you know, relationships improved.
Okay, Okay, good. So there was some sustainability there.
Yes.
There was a question regarding the baseline versus end line increases in the use of family planning methods. Could you explain over what period of time that was measured?
Yes. So the Bill and Melinda Gates Foundation funded our project from July of 2013 through December of 2013. And so our baseline was conducted towards the end of 2013, and implementation started January 2014. So really, it's over a period of, let's say, mid 2014, because we had to get the messages out and for uptake to happen. And our end-line survey was conducted in September of 2016. So I'd say over a period of 24 months, given, you know, a startup period and the end period.
Okay, good.
And if I may, you might be wondering about the auxiliary nurse midwives. After we had the centers had been reopened, we actually did send them to, we collaborated with the Ministry of Health and Family Welfare to give them refresher training, so that, you know, to upgrade their skills to provide quality care, since they had not been working. So we assumed that their skills may have, you know, gone down, or not be as sharp as we wanted them to be. So.
Okay, thank you. Also, Susan, can you provide some details as to what types of family planning methods were used for this intervention?
As an organization, we always defer to the country programs and what is offered. So we were going according to the state of the country's government of India's guidelines. So in Hardar and Lucknow and Uttar Pradesh, the key family plan options were intrauterine device, oral contraceptives, condoms. Those were the major three. At the time, injections weren't as popular, but I understand now a policy has been passed. But yeah, those were the three major ones that we were working with that were available at the local level.
Okay. Any natural family planning or?
Not as much, you know. At the baseline, we had like 0.2, and LAM was mentioned as one of the methods being practiced, but LAM is a modern method. But we realized that, you know, the three criteria weren't being always fulfilled, and so we didn't want to blur our results, and so we didn't really include that in the final calculations.
Okay, good. Now this is a question that we have for all the presenters, and each of you could take a stab at it. This question says, I'm curious about how many of the presenters found that having children was a means toward a social safety net for later in life. And is there any idea how much this affects family planning decisions?
I'm happy to start the answer, or?
Sure.
I found that men will volunteer the information that in Uganda, a man to receive respect and value is to have many children, and he earns a lot of value from God by having a lot of children, and particularly some boys. So that does perpetuate the problem. But when we talk it through and ask lots of questions, after a while we were able to devise the right questions and lead people to understand that being a father is such a privilege and an honour, that every child should be wanted and loved and cared for, rather than just having multiple children. So by the time they finish the week's training, they've actually seen that having many children is keeping them in poverty rather than releasing them from poverty. But that's a slow process. Someone else can join in.
Hi, this is Susan. In India, in Hardar district, which was the rural district, they didn't really see it as a safety net. It's just that they just had children. I think the idea was that the same old idea that if you have many children and some die, you still have a few around you. But on the flip side, in Lucknow, the economic message was really being bled out by the government. And so a lot of families were now looking to use longer term methods. And so most of the families that we were dealing with had 2 kids max, and then 3 kids. And when you went to the BMC, I forget the name in India, but it's like the health center, a lot of women were there to get longer acting methods and permanent methods.
Good. Sharon, do you have any comments on that question? Sharon, if you could just take off your mic.
Sorry, we were dealing with families who were interested in family planning, so didn't really explore those who were not.
Okay, thank you. Next question is for all of them. Were there any ways that the programs in Uganda, India, or Nepal used Christian values or biblical stories in the promotion and acceptance of family planning in your studies?
Go ahead.
Go, Susan.
Okay. We just work with the Ministry of Health, and so we just looked at the messaging from the aspect of healthy moms and healthy children and healthy communities. However, we did take advantage of global weeks that celebrated, like International Day of the Women and etc., to bring in respected religious leaders who would talk about the issue and encourage religious leaders at the local level to improve women's health and children's health by listening to the Ministry of Health and other NGOs, both international and local, in what they were trying to message. So that's what we did.
Thank you. I think, Marg, you had another answer to that?
Yeah, each of our lessons has a biblical reference. There are several lessons who have, you have to act out stories from the Old Testament. David and Bathsheba is one, and that's reference to faithfulness and ongoing HIV. Then there are biblical references. I can't think of it right now, but 2 Timothy, talking about a father being a father to their child and providing for their needs. So every lesson has a Bible reference at the end, and we encourage people to have debates, particularly around Genesis, you know, go forth, multiply and fill the earth. We encourage the leaders there to sit down and discuss what does that really mean today. So there's a lot of discussion around biblical themes and messages in every lesson.
And Dan, if I may interject, for India, the community was mainly Muslim and Hindu and a bit Christian, so it was a bit sensitive. That's why we used the respected local leaders and leaders at the state level. However, on the flip, since the moment was implemented also in Kenya, we used a lot of biblical stories and references, both from the Quran and the Bible to message during the Channels of Hope training that I mentioned at the end of in my last slide.
Okay, thank you. Yeah, that's interesting in that using the language of the local faith leaders and people of faith, I think, does help manage social transformation as well. And I think some faith leaders have been more receptive to the idea of family planning improving the lives of mothers and children rather than population control and other descriptors that may be more secular. This question is also for Marg. Do you use any materials only in English, or do you use in other languages?
Yeah, we've just completed 3 parts of our training in Swahili, and we're slowly moving through that, so step by step, and that's gone into Tanzania. So we have people from Tanzania, Zambia, Kenya and Ethiopia coming to the next training, but we are not quite able to keep up with all of that. I noticed someone else said that the Archbishop of Uganda is promoting family planning, and that's true. Archbishop Stanley is written us an endorsement for this training. He's really behind us, so we get a lot of positives. Thank you.
And Grace Tasler had mentioned that she worked in Uganda for years during the HIV epidemic, and sees the great progress in having men even talk about sexual matters, much less be involved with change. So that's a good progress there. Any the other Sharon and Susan, in terms of other languages that you use your materials with?
Well, our materials are all in Nepali, and we'd be happy to share them with anyone else who's interested to work in Nepal.
And this is Susan. Yes, all our materials are also in Hindi, and so we will be happy to share. In addition, I think there's a question about the auxiliary nurse midwife training and insertion of the IEDs. Dan, if I may go ahead.
Go ahead.
Yes, the auxiliary nurse midwives were sent for training. As I said, we collaborated with the Ministry of Health and Family Welfare, and so they went through refresher training. In actual fact, that training we did in collaboration with also JPIGA, because they were the clinical INGO at that time, and so they did insert IUDs. For other services, injections at the time of our implementation had not been policy, and so we're not providing injections. However, I know PSI was in Lucknow. And for any other services that were not offered by the auxiliary nurse midwives, they referred to the hospital.
Okay. Good, thank you. Sharon, there was a theory of, I just had a question regarding theory of change. This included implementation in a non-health sector, which is very interesting, in this case, agriculture. Like Marg's program, you mentioned the importance of involvement of men, but I think you targeted women's groups. Did you find that targeting women's groups helped secondarily affect men's decision-making, particularly in regard to vasectomy awareness?
It did. Remember, these were women's groups for agriculture, and so there was a lot of interaction between men and women in the family involved in agriculture, so it opened up opportunities for more discussions with the men. And there were also agricultural activities in DEEP that were targeting men as well, so there was an opportunity to bring in family planning discussions that way. So we feel that this was a way to reach a group that otherwise may not have been reached by traditional family planning approaches.
Good. And one other follow-on question, Sharon, is do you think that this could be applied, this particular program, to apply to other non-health sector programs such as WASH, economic development, et cetera?
Well, we do. Of course, we haven't tested it, but we think that would be a great way to move forward with further testing.
Mm-hmm. Okay. One question, following question for Marg. Besides targeting men, how did your theory of change inform the structure of your program? And what indicators, if you did have funding for measuring and evaluating, what indicators can you measure to show the evidence of the program building capacity for healthy timing and spacing of pregnancies?
Yeah, it's a difficult question for me. As I say, I know it's our biggest gap at the moment. Can I give an example, which is probably not completely answering the question, but just recently there was a program in Mbali where our country director, Joyce, went to the district Ministry of Health, and with a combination with Compassion, who did fund this program at that stage, they went to 52 schools and did a lesson on menstrual hygiene. And that was in order to keep young girls in school. In reaching 52 schools, they reached over 10,000 students in 3 weeks by dividing into into 8 teams. So one of the other authors in this, your journal, Moses has actually helped us since writing this and connecting with each other, and he's come up with some really great monitoring and evaluating tools. But can we measure if women are having more using contraception? The answer is no, I can't measure that yet. So it's still a great need we have.
Mm-hmm. Yeah, Marg is referring to the article by Moses Alakale regarding the attitudes and activities of pastors and faith leaders in Zimbabwe on the use of family planning methods among their members. We're going to close this session in the next few minutes, but I would like to encourage the participants to read other articles in the Christian Journal for Global Health issue on family planning that was published in July, and even consider submitting your own work for publication. If there are any questions that were not answered during this session, during this webinar, and you would like additional information, please email Kathy Erb at CCIH, and she will direct your questions to the appropriate person to create a dialogue in follow-up. This webinar has been recorded and will be available on the CCIH YouTube page, which can be easily accessed from the CCIH website, which, as I believe of yesterday, was a brand new product, and it's quite nice. So that ends our dialogue. Unless there is any other questions that you have, as I said, you could direct those to the contact information on the screen. And we do very much appreciate your time with us. If you don't mind, we'd like to close with a word of prayer. Dear Heavenly Father, we know that you care for the least of these and have set forth your people to be able to be healing agents in this broken world. We pray, Lord, that you would guide and direct your people throughout the world who are seeking to help promote health and well-being among children, among women, among families and communities throughout the world. We pray that this effort toward healthy timing and spacing pregnancies would help families flourish, that help relieve poverty, help promote well-being and wellness throughout the world. And we ask in Jesus' name, amen. Thank you again for joining, and look forward to having further dialogue later on.
Thank you, Dan.